let me just tell the women that are on there right now, we're going to have a 30-minute presentation followed by a question and answer session. And during the question and answer session, you guys can ask questions through chat, which some of you already used, or you can raise your hand physically, or you can use the raise your hand icon if you know Zoom well, know how to work your way through Zoom. There is an icon where you can actually raise your hand. So, but I'll keep all of the questions. None of the questions will be answered until after the presentation is finished. Okay. Yeah, I guess we can go ahead. Let me just welcome everybody to our webinar. The first thing I want to do is read a disclaimer. This webinar aims to provide evidence-based medical information for the diagnosis and management of adenomyosis. This webinar is for general information purposes only and is not a substitute for individual medical advice by your own doctor. Attending this webinar does not qualify the establishment of a doctor-patient relationship with the presenter. Please do not base your decision on treatment choice on this webinar alone. For those of you that don't know me, my name is Maria Yeager. I suffered from adenomyosis for 17 years and did not get a correct diagnosis until after hysterectomy. Not wanting any other woman to go through what I went through, I started Adenomyosis Fighters. I have also written 4 books on this uterine disorder. We are honored today to have Dr. Eisen Liang here to talk to us about adenomyosis. Dr. Liang is an interventional radiologist based in Sydney, Australia. He has a special interest in women's health. He's been performing uterine artery embolization, also known as UAE, for fibroids and adenomyosis for almost 15 years, helping women with menstrual issues to get their lives back without hysterectomies. 10 years ago, he established the Sydney Fibroid Clinic with interventional radiologists working side by side with gynecologists, focusing on uterine-sparing treatment options for women with fibroids and adenomyosis. His research papers on UAE for adenomyosis have been published in the Australian and New Zealand Journal of Obstetrics and Gynecology in 2012, 2018, and 2021. He has been an invited speaker at international conferences in North America and the Asian Pacific region on the topic of adenomyosis. He has just published his book, Could It Be Adenomyosis, the Bad Cousin of Endometriosis? Welcome, Dr. Liang.
Thank you,
and there's
Maria.
The book.
We talk about the book at the end.
Yes.
Thank you for your kind introduction. And hello, everybody. It's great to meet everybody on the cyberspace, to meet all the fighter warriors in Maria's group. It's a great honor to be invited to speak to you all. And I'm talking to you from Sydney, Australia, and it's down under there. And Sydney, Australia, I guess we're known for our harbor and the Opera House and the Harbor Bridge. And I'm speaking to you from about 5 kilometers from the other side of the Harbor Bridge, on this side. So I took this picture yesterday. I know today is going to be overcast. And so Maria saw this yesterday briefly when we were testing the technology. Okay, so Maria's read out the disclaimer, so I wouldn't waste time there. So today we're going to cover quite a wide range of topics regarding adenomyosis. And so we're going to talk about what is adeno, how to diagnose adenomyosis, why is it so difficult to make the diagnosis, what are the treatment options medically, procedure-wise, and in particular, uterine artery embolization. And we're also going to touch upon adenomyosis and fertility, and adenomyosis and endometriosis as well. So to start with, what are the issues here? So you yourself, or maybe someone close to you, might have been suffering from heavy menstrual bleeding and severe period pain. And you might have tried different medications, and yet none of them really worked to your satisfaction, or you might have developed side effects. and or you hate being a slave to all the pills. You want something else. You might have an ultrasound to investigate, but you might have been told either nothing wrong with your uterus, or maybe just some fibroids there, forget about it, you know. And you know that something more is going on, because your symptoms are so severe. So you know that you might have known that you have adenomyosis for some time, but failed to respond to the treatment that you've been given by your family doctors or primary physician. Or you might have met your specialist who told you that hysterectomy is the only solution, and you probably want to consider otherwise. Or you might have been troubled by endometriosis, and you had previous laparoscopy to clear it. And yet, for some people, even after laparoscopies, they still been suffering from heavy period and period pain. So you're wondering why. Some of you might have had endometrial ablation or contemplating endometrial ablation. This is a common question that comes up in the support group. You know, should I not to have an endometrial ablation? And for those who had it, you might find that the period pain is worse. So why that is the case? Or someone younger might have tried a series of, tried to get pregnant, and even had a few cycles of IVF, but troubled by miscarriages. So maybe you're just interested in women's health issues and you want to know more about adenomyosis. So we're going to talk about, you know, why is it so difficult to diagnose it? What are the treatment options? How good is Mirena? And this is a very common question on the support group discussion. Should you have an ablation? Should you avoid a hysterectomy? How good is UAE as an alternative to hysterectomy? How would adenomyosis affect someone's fertility? And how is endometriosis and adenomyosis are related to each other? So what is adenomyosis? And some people even find it difficult to pronounce. So I would say break it up. Adeno simply means glands. Myosis simply means muscle. So it is glands gone into the muscle. Glands should not have been in the muscle. Glands should be just lining the cavity of the uterus. When this gone outside, people all know it's endometriosis that causes period pain. I call adenomyosis as the bad cousin of endometriosis, because not only it causes heavy period, but it causes, not only it causes period pain, but also causes heavy period as well. So it can be diffuse or focal, and it is quite common, and but under-diagnosed and recognized in the clinical setting. If you look at the hysterectomy specimen, it is actually can be up to 40 to 70% of hysterectomy specimen. So it is not uncommon at all. And it is a benign condition, meaning it's not cancerous. So it causes heavy period because you have increased surface area for bleeding. Some of the glands are entirely trapped within the muscle wall. And as you know, if you have bleeding into a confined space, you're going to have severe pain at period time. Some women suffer from quite severe premenstrual bloating or pain, or both. That's because in the second half of the cycle, the linings start to thicken up, and they start to thicken up in a confined space, and therefore the woman might feel that they're bloated, even though if you measure the uterus, it might not have enlarged very much. So this is a pathological picture of adenomyosis, and it quite often coexists with uterine fibroids. But unlike fibroids, as you can see, it's the infiltrative lesion. There's no dissection planes, And therefore, we don't think this is a surgical lesion that you can successfully remove. It is a bit like removing chocolate from a baked chocolate muffin. You either have to remove too much, or you will have left something behind, causing recurrence of symptoms. Now, why is it difficult to diagnose adenomyosis? And that is because it has been really under-recognized by the medical community and the healthcare professionals and general public as well. So the key to early diagnosis is to educate the clinicians and educate the sonographers that this is an important disease to pick up. So if a woman comes into the rooms with heavy menstrual bleeding and severe period pain, they need to ring the alarm bell, raise the clinical suspicion. And this, in my opinion, is the key to early diagnosis. Therefore, we've written the book, and Maria written quite a few books trying to raise the awareness of this dreadful disease. We're sending this book to the ultrasound practices around us and trying to raise the awareness as well. Now, ultrasound signs can be subtle, and it might miss the diagnosis, especially when fibroids are present. MRI is more accurate than ultrasound, but as we know, it is a lot more expensive. Laparoscopy and hysteroscopy are not really the right test for adenomyosis because it is in the wall. So laparoscopy look at the outside of the uterus and other part of the pelvis, the lining of the peritoneum, the covering of the abdominal cavity, and hysteroscopy looks inside the cavity. So yes, sometimes you can pick up the signs, but it is not the best test for adenomyosis. CT scan is more or less useless in seeing anything, to differentiate anything within the uterus. Blood test, CA125 may be raised, but it is neither sensitive nor specific. So it is not a useful test for adenomyosis either. Why is adenomyosis a challenge for ultrasound? Now, first we have to realize that adenomyosis is not a single disease. It is a spectrum of disease. There's a variety of adenomyosis. Can be mild and superficial, can be diffuse and deep, it can be focal. When it's mild, ultrasound tend to miss it. When it's diffuse, ultrasound cannot see any focal lesion. So quite often in the report, they say, bulky uterus, meaning that I haven't seen anything really I can put my finger on. When they see a focal lesion, they say, this is a fibroid, because fibroids are in 70% of women. So any lump on ultrasound are potentially interpreted as a fibroid. This is a typical ultrasound appearance of adenomyosis. You can see this is the endometrial lining. You can see the asymmetrical wall thickening. One wall is far thicker than the other. You can see this venation blind artifact and heterogeneous echo. So this is quite a typical appearance of adenomyosis on ultrasound. But if the walls are symmetrically affected, then it becomes harder to detect adenomyosis in ultrasound. Quite often we see cysts in the kidney, in the liver, in the pancreas. So cysts are common, but cysts are not supposed to be present within the uterine muscle wall. So when you see a cyst in the uterine muscle wall, it's more or less diagnostic of adenomyosis, but not many people realize that. There are many subtle signs, ultrasound signs has been described, but really the sonographer have to really look very hard and to make a diagnosis, and quite often they're not certain. MRI is a lot easier. MRI depict the pathology very easily. First of all, the cavity, which is the gland tissue, you know, the endometrium, they're very bright on MRI. So if you can see this bright tissue within the wall of the uterus, and that's adenomyosis, okay? You can see the muscle thickening there as well, okay? So you can see the so-called thickening of the junctional zone, which is due to reactive muscle thickening, and together with the positive findings of ectopic endometrial glands. Junctional zone is a very, is the inner layer of the muscle. The cells are tightly packed. That's why on MRI it appears dark. And this is normal junctional zone. In adenomyosis, because that layer is infiltrated by the abnormal tissue, so the junctional zone showed thickening, and you can also sometimes see these bright foci of endometrial gland as well. So on MRI, it's very easy to pick up adenomyosis. Sometimes you see a focal lesion on ultrasound here, and quite often they don't know what it is, and they can't be definitive, but MRI is easy. Once you see this, it's an infiltrative lesion, unlike fibroid, and it's got this bright foci within this dark area. So no doubt this is a case of adenomyosis. MRI is particularly useful when there are multiple uterine fibroids as well. And this situation is particularly challenging for ultrasound. Ultrasound can pick up the fibroids, but quite often they can't see what's going on here. In MRI, it's very easy to distinguish these well-defined dark nodules, and these are all fibroids. But here is infiltrative lesion, thickening of the junctional zone, plus these trapped glands, even with bleeding blood signals in it. So this is adenomyosis amongst fibroid. In fact, in my clinical practice, the two conditions coexist in about 50% of the cases. So both are common conditions, and therefore it's not surprising they can coexist. It can be tragic if the ultrasound diagnosis was wrong. Like in this case, this woman was taken to operating theater because ultrasound reported it's a large fibroid. The surgeons worked on this for 4 hours, could not get it out because of the heavy bleeding encountered during surgery. So they abandoned the surgery, sent her back to me, and sent her to me and say, hey, can you embolize the fibroid? When I did the MRI, it wasn't fibroid at all. It is entirely adenomyosis. Note the uterine volume, 1,427 mil, which is about 14 times normal than larger than the normal uterus. And this, she required 2 sessions of uterine artery embolization and to control her symptoms. Now, we're going to talk about therapies. So I'm just going to touch briefly on medical therapy because that's generally as a first-line treatment given by primary physicians, and made that, so that usually there are 4 categories: the pain-relieving medications, the menstrual flow reducing medications, or menstrual cycle suppression medications. And the last one is medically induced temporary menopause, and that's probably usually given by gynecologists. So the pain-relieving medication, the mainstay is what we call the non-steroidal anti-inflammatory drugs. They are particularly helpful in relieving period pain. Because it blocks the prostaglandin production. And the key is you need to take this medication before the period comes, before the pain starts, for that to be most effective. And you can add other things like medication on top of this, but this is the mainstay of pain relief for period pain. To reduce menstrual flow, we can use tranexamic acid. The trade name here in Australia is called cyclocapron. Basically, it shifts the balance towards clotting. It is a drug that we use in trauma situation and in women with heavy menstrual bleeding, but also in postpartum hemorrhage as well. And so it is contraindicated in someone who has thromboembolic disease like thrombosis in the legs or clots in the lungs or previous strokes. So in general, it is safe, and the chance of this drug causing thromboembolic disease is quite small, but it may not be a good long-term solution. The next one down is menstrual suppression, which means that you use oral contraceptive pills or progesterone-only pills or implants to suppress a menstrual cycle so you don't have a period pain or heavy bleeding. But some women are reluctant to be on hormone all the time, and some others suffer from side effects from mood changes, weight gain, migraine, etc. And medically induced menopause, that's using gonadotropin releasing hormone analogs that can be in the form of nasal spray or injections. And generally it's limited to 3 to 6 months of usage because it can cause osteoporosis if that's used long-term. And it's been found to improve IVF success rate. So in younger women who are symptomatic, who are ready to get pregnant. So this may be something we can do to control the symptoms, to recondition the uterus, and allow them either to try natural pregnancy when they're younger or when they're closer to 40, perhaps, use as a pre-treatment before frozen embryo transfer. And the next thing is Mirena IUD, and this is very commonly raised question in the support group. I have observed, and some women likes it, and some women hate it. And it has been shown in the studies that it does alleviate adenomyosis related heavy menstrual bleeding and period pain in the majority of women. And the satisfaction rate is about 56% at 12 months. The common side effects are irregular bleeding and spotting, and women are encouraged to persevere for 3 to 6 months and to allow the Mirena to settle in. More recent study has shown that Mirena may not work well for uterus larger than 150 mils. So what that means is that if you have more extensive adenomyosis, Mirena, the progesterone released from the Mirena may not be enough to suppress the disease. And there is a long list of side effects, and this is a list from Bayer Consumer Medicine Information on the website, as you can see. And so I come across a biased group of women who either failed Mirena, which didn't work, or fearful or suffering from some of the side effects. So they don't want to, either don't want to go use Mirena, or they want the Mirena to be removed. And the next thing is endometrial ablation. Now, and that's a commonly raised issue in the support group as well. My gynecologist suggests I should have an ablation. Should I have it? Now, we just have to remind ourselves adenomyosis is a disease involving the wall of the uterus. It is within the uterine muscle wall. It's here. Endometrial ablation it uses heat energy. It only destroys a few millimeters of tissue. So it meant to only destroy the lining of the uterus. In other words, anything deeper than a few millimeters within the wall is not going to be treated by this. And in fact, far more glands are going to be trapped or isolated within the uterine muscle wall. And therefore, we have seen many women who has had ablation come back with much more severe period pain. So the important message I have for clinicians is that when period pain is present in a woman with heavy menstrual bleeding, as well as period and adenomyosis need to be suspected, and the diagnosis need to be established, because missing adenomyosis can lead to inappropriately choosing ablation as a treatment for heavy menstrual bleeding. And the period pain can be far worse after ablation. And so I think endometrial ablation is to be avoided if adenomyosis is the diagnosis for that woman. We have treated successfully post-ablation pain and with uterine artery embolization. Surgical resection, we've already said that it's because of no clear boundary, and this is really not a surgical lesion suitable for resection. Hysterectomy is usually said to be the only cure for adenomyosis. And I think this is true in the past, but now we have other options we're going to talk about. I'm just going to go quickly over some of the hysterectomy issues. It is a general anesthetic procedure. It is a major abdominal surgery. It does require 3 to 5 days in hospital and 4 to 6 weeks of recovery. And so irrespective of how that's done, there's always anesthetic risk for blood transfusion, wound infections, and injuries to the bowels, bladder, and the ureters. Even to date, this is data from 2019, the severe complication rate from hysterectomy is still quoted to be 3.5 to 11%. But there are not only the acute risk we have to consider, there are also long-term side effects of a hysterectomy people tend to forget. Number one is prolapse and incontinence, and the risk is increased. Early menopause by 4 years, increased cardiovascular risk, and sexual dysfunction, because you have to, do dissection, and some of the nerves may be damaged. So it's not surprising you might have some sexual dysfunction or even constipation after major surgery down there. And this is relatively new, hysterectomy and cardiovascular risk. This is from Mayo Clinic 2018. Even with ovarian conservation, meaning that you leave the ovaries behind, the risk of coronary artery disease is increased by 33% in women with hysterectomy only. And the risk is increased by 250% if the hysterectomy were performed in women younger than 35 years of age. So this is not insignificant. So what's the alternative to hysterectomy? This is relatively new, and that is uterine artery embolization. It is a non-surgical procedure performed by interventional radiologists. It works by shutting down the blood supply to the uterus. We know that tissue cannot survive without oxygen. So we starve the adenomyosis of oxygen, and you will shrink and die. It is a local anesthetic procedure requiring generally one night stay. In North America, they encourage to be done as a day procedure. So quite often they go home in the evening. Usually you need 1 week of recovery, and meaning that taking things easy and resting at home. And probably by day 4, day 5, you're well enough to drive the kids to school or go to a local supermarket. And UAE is 90% successful in treating adenomyosis related heavy bleeding and period pain. And to many women, it is life-changing. It is the most effective uterine sparing alternative to hysterectomy. So how is it done? It's done under local anesthetic. We access the artery under ultrasound guidance, and we pass a catheter, which is a small tube, about 2 millimeters in diameter. Under X-ray guidance, we cannulate the left and the right uterine arteries. Once we're there, we're going to inject some particles to shut down the blood supply to the uterus. Now, without oxygen, the adenomyotic tissue will die. Some particles will end up in normal part of the uterus. However, uterus is rather amazing. As you know, during pregnancy, the uterus expands enormously and carries with that 40 times increase in blood flow. So when the fetus, when the baby is born, the uterus will contract down and the blood vessels will shut down as well. So the normal part of the uterus has this immense capacity to recruit and reopen dormant blood vessels and to keep itself alive. And the adenomyotic tissue, however, do not have that capacity, and therefore, once the blood supply is shut down, the adenomyotic tissue will shrink and die. As you can see here on this MRI, you can see the abnormal endometrial tissue there, thickening of the junctional zone. And this is after embolization. You can see a normalization of the junctional zone and the disappearance of the adenomyotic tissue. Here's another case with diffuse adenomyosis, thickening of the junctional zone. And after embolization, you can see the normalization of the junctional zone, and the uterus looks perfectly normal afterwards. This is a case of focal adenomyosis, and after treatment, it's shrunken down to a scar nodule. Here is quite a massive focal adenomyosis, and shrunken down becomes inactive. And what you can see is the normal part of the uterus remains normal, and only the adenomyosis is dead. It works for all kinds of adenomyosis, whether focal or diffuse, whether small or large, because it is really the left and the right uterine arteries that we are treating. So there's quite a lot of studies on this. There's 30 studies in 10 countries was included in a meta-analysis in 2018. And this did not include our study, which happened to be published in the same year. So ours is not included in this. But in this meta-analysis, they're already saying, for short term, you're expecting about 90% symptom improvement, whether you have fibroid or not. In fact, with fibroid, the success rate even higher. The long-term success rate is ranging between 75 to 85%, better if the adenomyosis is together with some fibroid. The important thing to note is the hysterectomy rate, because all these patients are potential hysterectomy specimens, and only, candidates, I should say, my apologies. And the hysterectomy rate is only 7% In other words, UAE potentially can save 93 out of 100 women otherwise who require a hysterectomy. We noticed that it works for adenomyosis as far back as 2012 when we were auditing our result of UAE for fibroid. We just happened to discover that about 30% of our patients also have adeno, and it works really well for adeno. So we systematically study the woman with adenomyosis, 117 that we have treated with UAE, and published in 2018 in the ANZ Journal of ONG. And here's our result. Average follow-up of 22.5 months. 90% of women are happy or very happy with the outcome. Their periods are either back to normal or lighter than normal in 90% of cases. The pain score drop is significant from 7.45 out of 10 to 1.3 out of 10. This is very, very significant improvement of their pain. And we don't have any major complications at all. And on our hysterectomy rate at that stage is only 5%. And we did have 2 successful pregnancies out of that group. This year, we published again the same cohort of women. We did a 5-year follow-up, and we've proven that UAE is not only effective in the short term, it is also durable as well. The side effects are pretty much what we call post-embolization syndrome, that is pain, nausea and vomiting, usually the first 24 hours, followed by some lethargy and low-grade fever in the next few days. So that was UAE, and as an alternative to hysterectomy. And I'm going to move on to just touch upon the issues of adenomyosis and fertility, and that a lot of women are concerned about that. But I have to start with some inconvenient truth. Adenomyosis does increase the risk of miscarriage and premature birth. Adenomyosis can cause fetal growth restriction and poor neonatal outcome. Adenomyosis has been shown to reduce IVF success rate, and miscarriage after IVF can increase. If you surgically remove the adenomyosis, there has been reported increased risk of uterine rupture and during pregnancy. So I think the important messages for healthcare professionals, from family physician to gynecologists to the fertility specialists, are that for women with heavy menstrual bleeding and period pain, we should raise the suspicion of adenomyosis. Early diagnosis at a younger age is important. When diagnosis is still relatively mild and still treatable with a GnRH treatment, which might increase the chance of that woman getting pregnant. Women who already have extensive adenomyosis should be forewarned about reduced IVF success rate before committed to costly IVF cycles. And also the woman should consider pre-treatment with GnRH to increase the chance of successful and pregnancy. I think MRI is very useful and to distinguishing fibroids from adenomyosis and to make the definitive diagnosis of adenomyosis and to visualize the extent of adenomyosis, and that hopefully at some stage in the future we can quantify the chance of a woman getting pregnant if they were affected by adenomyosis. Uterine artery embolization is a uterine preserving procedure. There has been many case series documenting the success of successful pregnancy after UAE for fibroids. However, we have a lack of data on fertility after UAE for adenomyosis. What we're not sure is that if UAE improves fertility or not, because it is a complex issue, because the disease itself has negative impact on fertility. So it is a complex puzzle to solve, and I'm yet to see anyone come up with a good study to demonstrate that. The important thing that we need to warn our women is that if they want to have UAE for adenomyosis, if they have exhausted all the other treatment options, if hysterectomy is the only other solution for them, they still need to be aware of the potential 1 to 3% chance of ovarian failure with UAE. And so we talked about GnRHA before, and that can improve fertility in women. And the final topic in this session I want to talk about is adenomyosis and its cousin endometriosis. Now, study has shown that two diseases are strongly associated and can be coexisting in the same woman in 80 to 90% of cases. Some even consider it is a variant of the same disease. So how do we approach this? If it's just period pain, then perhaps it is maybe just endometriosis. But if it is period pain, if it's heavy menstrual bleeding in addition to period pain, I think we should not forget adenomyosis. We should scrutinize the ultrasound findings, and we should consider MRI to make more definitive diagnosis. Both diseases can cause fertility issues. Endometriosis causes tubal blockage, and adenomyosis can cause implantation failure, miscarriage, and premature birth. Now, my approach is this. If you are suspecting endometriosis only, then perhaps should go ahead with laparoscopy. But bear in mind, it is a general anesthetic procedure, an invasive surgical procedure requiring 3 keyholes in the tummy. If there is also heavy menstrual bleeding in addition to period pain, perhaps we should consider using MRI to establish the diagnosis and consider UAE as the treatment option because it is a local anesthetic procedure and is less invasive. Medical therapy for both conditions are actually quite similar. All right, so I think, is that a signal that time is almost up?
No, that was my phone, but yeah.
Right, I got your message, Maria. Okay, so I'll summarize. Okay. All right. So in a woman with heavy menstrual period pain, we really should raise the suspicion. If ourselves don't raise the suspicion, or your primary care physician didn't raise the suspicion, the sonographer might miss the diagnosis and we will never really miss the chance. We're going to miss the chance of early diagnosis. And it's quite a challenge for ultrasound to make the diagnosis in many cases. And in fact, in our area, 71% of ultrasound has missed the diagnosis. MRI is more accurate, but it's more expensive. First-line treatments can be tranexamic acid for heavy bleeding, non-steroidals for pain, and maybe menstruation suppression with continuous oral contraceptive pills or progesterone treatment. Mirena IUD, it does work in 56% of women, and we must bear in mind that for more extensive adenomyosis, especially uterus more than 150 mil, women need to be forewarned that Mirena may not work. UAE is a minimally invasive local anesthetic procedure, not performed by the gynecologist, but usually done by interventional radiologists. And we have 90% success rate, and it is minimally invasive, and it's uterine sparing, and is potentially a life-saving, life-changing procedure for many women. Ablation and surgical resections are generally contraindicated for adenomyosis. And hysterectomy is the only cure in the past. It should be used as last resort because of the acute surgical risk for any major surgery and the potential long-term side effects. And it should only be used when all the other less invasive treatments have failed. So, well, that's the conclusion of my my presentation. I'm not going sailing today because we're going to have thunderstorm in the afternoon. I'm going to just chill out and relax. And this is the book we wrote, trying to raise awareness of this dreadful disease, and trying to show women how to get their life back without the hysterectomy. Thank you very much for your attention. So most of the information that I presented, you can find more detailed discussion within the book, and the references are also in the book as well. And you might also want to visit our website, sydneyfibroclinic.com.au, and that contains a lot of information on adenomyosis and So you can purchase the book from Amazon, or there's ebook available as well. Thank you very much for your attention. And we open up to questions, I suppose.
Yes. Thank you, Dr. Liang, for that amazing webinar. It is full of valuable information. Anybody that wants to ask a question, you can ask through chat. And I will pass the question on to Dr. Liang. From Emily, is there a way to get a copy of the slides for this?
Okay. I haven't put them online yet, but we have recorded the session, Maria, and Maria is going to, at some stage, put them on the YouTube channel.
Yes, I am.
Yeah. So if there is still a strong request for the slides, I can try to make them available. But a lot of the illustration that you've seen on the slides are actually on our website. You will find them, and in my blogs under adenomyosis itself, and like the treatment options. So the illustrations are there, and the blogs are the longer discussions as well.
Okay.
And for example, why adenomyosis is so difficult to diagnose, and there are these illustrations and MRI pictures there. So you find most of the illustrations and the and also the case studies on our website. So.
Yeah, thank you so much. I wanted to thank you in person, come on and let you know that somebody was behind, all the little names up here. And also, Maria, thank you. Your book was like the first thing I grabbed when I got my diagnosis. So I want to thank you for that. And I look forward to getting your book, Dr. Liang.
Thank you.
Yeah, I'm also hoping to put together an adenomyosis podcast and ask if both of you would come on. So maybe we can set that up, talk about it. Anybody also watching this, please get in touch with me. I'd love to put stories out there, get awareness out there. So thank you so much for this. So
I can see you are really, Emily, before you go, I can see you all professionally set up.
Yeah.
Is my voice coming through clearly enough, good enough for you?
Well, here's the thing. Adenomyosis happened to hit a Webby nominated podcaster. It hit the wrong person. So it's getting out there into the world. We're going to get more awareness out there. So thank you.
Wonderful. Yeah. Wonderful. So you're a big podcaster. I didn't realize that. Okay.
I tell you what, Emily,
yeah.
The reason we wrote the book is treating this disease more for about 10 to 15 years. Even as recent as last week, I still have women coming to me and saying, I've seen so many doctors, I've had so many scans. I get told, I just had the fibroids. I didn't know that was, I've never heard about it. Nobody mentioned about it. It's all missed.
Those stories they hurt. And I was told 5 years ago, oh, it's just a little endo. And I got sent on my way. So, and you hear stories like that over and over and over again. And then it takes people raising awareness and making things relatable. And, oh, you have a really heavy period too. Oh, your ovulation hurts too. Oh, let's talk about this and figure it out, and talking with other people and finding community that's really going to raise awareness.
Yeah. One of the major issues that what I found is that, if you have a hammer, everything else is a nail.
Right.
Right. Yeah. So what happened is, I believe that's probably very much in where you from as well. I guess Canada or United States, and that the primary physician will treat the woman first, and if they not getting anywhere, they refer them on to usually the next specialist will be gynecologist. Okay, so what are the tools of gynecologists? Hysteroscopy, look at the inside of the cavity, or laparoscopy, looking at the outside. But this is within the wall. Okay, so you're using the wrong tool because they haven't got a tool to diagnose this. So it tend to be neglected, unfortunately. So to diagnose this, ultrasound is your first choice, but MRI is far better. But unfortunately, I'm not sure about in the United States or Canada, but in Australia, MRI is not rebatable by Medicare, meaning that a patient have to pay every single cent to have the MRI done. So which is unfair, which is a battle that we're trying to fight here.
Well, we want to thank you, Dr. Liang, for doing that. We need more people like you out there, for sure. I want to just share one thing. Emily was talking about how, they pushed her off to saying, oh, yeah, that's just a little bit of, endo. This, I think, kind of brings it home as to how painful this condition can be. Like I said before, at the beginning, I went through 17 years of adenomyosis and went back and forth to all kinds of different doctors and got nowhere. And then about 2 years ago, I ended up with a case of pancreatitis from a gallstone. And I was in the hospital for a week. And one day the nurse came in to me and she said, oh, I feel so sorry for you having pancreatitis. I heard that's one of the most painful things that you can have. And I almost laughed because the pain from pancreatitis is way down here and adenomyosis is way up here. And I'm like, it's not even in the same class. The pain is so much worse. And that's what really just propelled me into starting the support group and writing the books. Is I want the general public and the doctors to put a lot more effort into finding out what's causing this and how to treat it, because I don't think people in general really understand how painful and how disruptive this disorder can be in a woman's life.
Yeah, sometimes it's the attitude as well. And I've got women that come to me and saying that, after treatment, they've been suffering from heavy period pain for decades. And then after treatment, they come back for follow-up and saying, hey, by the way, I didn't realize period didn't have to be painful. They always been told by their mother, by their grandmother, that their cousin, or even their woman's female GP that, what's wrong with you, just a little bit of pain with periods, and put up with it. I mean, that's really a very wrong attitude. And it is wrong to assume that periods should be painful and heavy. Yes,
I agree. Natalie just said, thank you very much for the interesting talk. So I don't have any other questions right now, but I do have a personal question I'd like to ask. In that pathological picture of the uterus.
You still seeing my screen at the moment?
Yes, I am.
Okay. Yeah. Yeah.
The actual pathological picture of the uterus with the adenomyosis in there. I'm seeing the what I consider the adenomyosis lesions in the junctional zone, but not as many in the outer, the myometrium, the outer myometrium. Does adenomyosis generally affect mostly the junctional zone part of the?
It really can be anywhere. I'm just going back, back adenomyosis, and okay. All right, there we are. This one here. So it's, as I say, it's a spectrum of disease. So it can be anywhere. So the mild form starts in the inner layer here of the muscle. It can be deeper, and it can be focal, can be cystic, and it can be on the outside as well.
On the outside.
On the outside like that, it started to merge with what people call deep infiltrating endometriosis. So that's what they can merge there. So you can, so it can be really anywhere. By definition, it should be within the uterus. Once it's entirely outside the uterus, then it's called endometriosis.
I see. Okay, thank you for clarifying that. Someone has sent a message here. Let's see. Juanica Joseph. This is just, it's not a question, but it's a statement. Thank you for the presentation. It has been so informative. I'm from a gem in the Caribbean called St. Vincent and the Grenadines. We don't even have an MRI here. I was diagnosed via transvaginal ultrasound a few months ago after my gynecologist suspected only endometriosis, but thought there might be more due to heavy bleeding and severe pain. Thanks.
Yep. So her gynecologist switched on, and he or she was on the right track, you know,
Yes.
to think about adeno, because people tend to forget that heavy bleeding is, I mean, if you have endo only, you shouldn't have heavy bleeding. If you have heavy bleeding, it's not the endometriosis, it's the
Yes.
adenomyosis. So that's an important concept some people forgot.
Okay, that's good. And does anybody else have any questions for Dr. Liang? I'll give him another minute.
Any comment if they want to raise their hand? Can you see everybody, or they have been muted?
Oh, here's one. Juanica wanted to know, with a tilted uterus, does it contribute to any of the additional pain from adeno?
I don't believe so. You know, the uterus can be uterus by itself should be mobile, so it can be, you know, anteverted or retroverted, anteflex or retroflex. So the uterus is only fixed at the cervix, at the neck. The body should be freely mobile, forwards and backwards. As your bladder filled up, the uterus get pushed out of the way, standing up, right? So, but if the uterus is affected, especially by endometriosis, you have scarring on the outside, so the uterine position can be somewhat fixed and less mobile because of the inflammation, scar tissues. And if the uterus is getting too big, it becomes less mobile as well, because its movement is restricted by other structures in the pelvis as well. So the position of the uterus itself is not going to cause more pain, but what's related to that particular position may be the source of pain.
Okay, that's good. That's a very good explanation for that.
Thank you.
While I wait I'll wait another minute for any additional questions. But I'll just make a comment. In my books, I'm going to have to update a couple of my books because of the information that you've shared. I definitely want to update it with more current information about UAE. But I also was interested to learn that the CA-125 was not specific or sensitive, because I've read some studies where they have shown that an elevated CA-125 could be indicative of adenomyosis.
It can be, and it is raised in endometriosis as well. That's what I mean by it's not specific. And
okay.
So it's basically, and some people say it should not be even used as a cancer screening, because, you know, it just can be raised in benign conditions. Some even say, I think I heard somewhere, don't quote me, even fibroid can raise that as well. So that's what we say is, yeah. But adenomyosis, you know, for many women, that when it's not sensitive, meaning that you can have the disease, but the CA-125 is not raised. That's what we say, but it's not sensitive to detect it. It's not specific, okay. It's because if you have raised 125, it doesn't mean that you have adeno. It could be a variety of other conditions can give raise CA-125. So that's why we don't think it is helpful in making the diagnosis.
Okay. There was a doctor over here in the United States that I talked to that basically said the same thing, that it's raised in so many different conditions that it's really not going to help them to come up to a final diagnosis.
Yes, I agree. Yeah.
Yeah. Okay. I just have another thank you, Dr. Liang. It's from Jillian. Thank you, Maria and Dr. Liang, for this presentation. Very informational. Understanding the condition helps to empower those of us who suffer from it. And I agree, Jillian, absolutely.
Yeah, thank you for the positive feedback.
Yes.
Jillian.
Well, I think, Dr. Liang, I think that will be it for tonight. And I want to thank you once again for all your hard work in putting this together and talking to all of us and helping us to understand this condition.
Yeah, it was my pleasure and honor to be talking to you and your group.
Great. Well, I hope to talk to you again soon. And thank you, ladies, for joining. I'll make sure to put this up on YouTube as well.
Have a good day and good night, everyone.
Bye.
Wherever you are. Bye-bye.
Bye-bye.
Bye-bye.